When do you feel pain? What is your understanding of pain? Have you ever felt it?
Yes, sir.
So what is pain? What is pain? Yes, Assis?
Feeling.
Assis?
Yes, so we can get a cut or when we get bleeded, or sometimes when huge amount or some more amount of force we get on our muscles, we get pain.
How do you feel? The question is very simple. When there is a pain, what happens to you?
I
When
feel restless
uh,
and uneasy,
yes,
and I can't bear it. I always wanted to get rid of it.
okay, okay. So which kind of pain uh, have you felt? Is it bodily pain you are talking about, or
Yes,
a pain which has no bodily origin but there is a pain,
this time I talked about physical pain,
physical
physically
pain?
on the body.
Okay, Akash.
Sir, I think pain is two types, sir. Mental pain and physical pain.
Hmm.
And the both have severe situations. Like sometime I had a ligament operation about a 6 months before. And
Hmm.
when I had that operations, I used to always take painkillers, because if I do not take the painkillers, I did not sleep at that night, and was like I was to cry. I have to cry for that because of the operation pain, sir. And that
Hmm.
was so. Some pains are not as severe as that. Like I touched a hot glass, and
Hmm.
then a little pain is only for stayed for 2 or 3 minutes, and it's a normal, yeah, not so much severe. And there is any kind of issues like a mental pain, such as
Hmm.
if somebody broken up, then he's mentally distressed, like that. These types of things are mental pains, I think.
Okay, which pain is difficult to bear?
Sir, if if it's a mental pain,
Hmm.
it's just too much long than physical pain sometimes.
Hmm.
If whenever this mother is died, then
Hmm.
he is so much disappointed, and at a certain amount of time, like 1 year, 2 years, sometimes it decreases day by day, but when it's happened, it's too much. So,
Hmm.
and sometimes sir, they both mental and physical pain are both equal, I think.
Okay, okay. Yeah, right. Pain is not a good experience, be it physical or mental. And mental pain are long lasting. Physical pain still can be managed. And with medication or with some kind of exercises, you can somehow get rid of the physical pain. But getting some relief from mental pain, there are not very sure short methods that you will definitely be cured of your mental pain that you are getting. Because the origin of mental pain is in the mind of the individual. And our mind is not under our control often. So you take any kind of methods to get rid of that mental pain, it is not going, because you are bouncing back to think the same situation again and again, because it was so stressful, it was so impactful that you can't forget. You stay with that kind of feelings for a longer period of time. So managing psychological pain or mental pain is difficult, though tolerable, tolerable, but very difficult. I mean, you can't get rid of it within a short span of time. That's the basic difference between physical pain and mental pain. But what happens in physical pain? Mostly you get a painkiller, and painkiller is a symptomatic treatment. It affects that moment, that time, that point of your pain is getting some relief, and you say that, yeah, now I'm feeling better. But most of the pain that you have in your lives, you would see, if you majority of your pain from your thinking, and even you can overpower your pain by making yourself more strong psychologically. Think about the football players. While they are on the field, they are also hit by another player, but still then they gather the courage to again get up and play. In many of the, you think about boxing, isn't it painful? Extremely painful. But still then, their mental strength is much more than the physical pain they uh, get. So that's why they can surpass this. Many a times there are no medicines for your physical pain. You have to bear it. Think about an extreme temperature. Extreme. Be it too hot or too cold. Not many people can tolerate that. So what do you do in that situation? You have no control over the temperature. Either you have to bear it or you lose the battle. Think about the soldiers who are there in the Siachen glaciers, those who are there in the deserts. Are they not taking any pain? Everyone is taking some kind of pain. But when pain controls you, then probably you lose control of everything. And if you can make yourself strong enough to challenge that pain, you can uh, you can easily overcome them. You can easily overcome them. So pain is a complex, multifaceted perceptual experience. It's a perceptual experience because for the same kind of uh, experience, same kind of uh, uh, a situation, not everyone gets same kind of pain. For someone it is too much, and for somebody it is nothing. So it is a perceptual experience that demands an explanation. So pain is a complex, multifaceted perceptual experience that demands an explanation. As a sufferer, an inability to make sense of the often worrying and persisting uncertainties of pain forces many to retreat from life's pleasures. So it is therefore vital to ensure collaborative facilitation of meaning in those who live with pain. And to do that, educational skills that we have, we don't teach about pain or pain management in any of the medical courses? How, what is the origin, what is how it can manage that pain? Not many training are given in this direction. And what is patient education in this sense? How patient is educated? It's a set of planned activities designed to improve a patient's health behaviors, health status, or both. And these activities aim to facilitate the patient's knowledge base in order to help them make sense of their pain and guide them towards effective ongoing self-management. What happens when you have a headache? What's the quick fix solution when there is a headache? What do? How many of you have a frequent headache? What do you do then? What is the best solution for your headache you do at that moment? Asis, Sandeep, Pooja.
Yes, so I sometimes close my eyes and sleep for a while.
Can you sleep with a headache?
When I feel heavy
Uh,
in my brain, that time I sleep, sir.
and you don't take any medicine?
No, sir.
Okay. Sandeep, what do you do?
I usually sleep, sir, or else I'll listen to some music.
I'm talking about headache. Can you listen to music while you are
Yes, sir. Like I read in some article, some ocean music makes you feel good.
okay, okay. Pooja,
So I take medicine.
take
For,
medicines.
yes.
Okay. So see that we have three different approaches to manage the pain. We just saw. Uh, Someone is resorting to music, someone is resorting to sleep, and someone is going for mm, medicines. Uh, and there they give results. Your pain subsides. Some methods take more time, some methods take less time, but I suppose the medicine method takes less time than the other method. I do not know whether we can do some kind of study on this, like when you have a severe headache, how do you manage, and in how much time you get the relief. So if somebody is going for sleep, after 3 hours or 4 hours, he or she might feel good. Somebody is listening music, maybe 1 to 2 hours or 3 hours, or medicine, maybe 15 minutes to 20 minutes or 30 minutes, it's done. We do not know. We can go for a survey kind of thing to understand which method is more effective. Now, it's not all the time that the doctors has to intervene. Doctors have to intervene in managing the pain of the patient. It's more important how the patient is getting education and manage their pain. When you have a stomach, when you have headache, all these aches are a type of pain. Some people get well without having any medicine. Some people can't stay without any medicines. As soon as pain is there, they go and open the medicine box and get something, quick fix. So to facilitate an understanding of pain's complexities and the importance of self-determined sustained self-management, we must first develop facilitatory skills. And facilitation can be defined as a technique by which one person makes something easier for others. Helping and enabling are central to meaningful facilitation. Yet, the desire for practice-based educators to ensure efficient and effective learning often leads to concentration on what they are doing rather than what the learner is doing. Even though patient education has been viewed and practiced as a preventive strategy measure, it includes all the information about the disease, disorder, or condition the patient is concerned with. Education is a vital part of rehabilitation from pain, a process which requires the acquisition of new knowledge and skills. This requires the ability to concentrate, understand, and process information. The information must also be retained, retrieved, integrated, and used in a meaningful way. Now, let me give you an example of a very common example that you and I, we all face it as of today, being we have some commonalities like we use computers, laptops, or mobiles very frequently, isn't it? Now, while using those devices, we sit in a particular position or we lie down and we watch movies or we watch web series, whatever. Now, being in a particular position for a long period of time also amounts to some form of pain in the body. And we all have experienced eye strain and eye pain. So we know how to get rid of this. Many of us have that education, isn't it? What's that education? That the rule is 20-20-20. When you look at the system, you must have this rule 20-20-20. After every 20 minutes, take a break and look to both the sides, or maybe you can uh, uh, do an X for the eyes 20 times, or you may blink your eyes 20 times. So all these exercises we know, but how many of us do that? While we are engrossed in an activity, we forget to do this. Now, with passage of time, that condition is getting worse. And we consult a doctor. The doctor gives some medicine and some painkillers also included in that. It is necessary to take care of yourself. In health psychology, we try to focus on the patient awareness. We are not talking about what a health professional will do for you. Rather, the patient is empowered to do whatever is desired to remain in a good health, to keep the health in a good condition. When including patient education as part of pain management program, there are certain topics which should be covered to address the areas pertinent areas patients often have concerns or misunderstandings about. These topics include the anatomy and physiology of the affected parts. Suppose I talked about eye, you talk about ears, muscular system, we can talk about any of this. Anatomy and physiology must be there to understand. The multifaceted nature of persistent pain, the difference between acute and chronic pain, triggers and flare-up management, fear avoidance and pacing, the role of exercise, the role of physiotherapy and other treatments, interventions, realistic expectations about a diagnosis, cure, and goal setting. Most of the time, we want a quick fix. We want a solution immediately. But as you know, the quicker you get a solution for a problem that has been developed within a course of time, with a good window of time, and we are trying to break that chain quickly, it has bad impact on our health. We all know that. This is called adverse drug reactions. Nowadays, we are gulping medicines like they are our breakfast, lunch, and dinner. You can find in your homes. Look at your parents or your grandparents, how they are eating medicines like as if they are their breakfast, they are their lunch, and they are their dinner. We are so much dependent on medicines. It's called drug addiction rather. It's not kind of a healthy sign and symptom to keep someone in a good health. A doctor prescribes. There is no other way. You are helpless. You can't keep yourself healthy without taking these medicines. But can you keep yourself healthy with these medicines? That is also not guaranteed. So what is to be done is you make yourself responsible for your health. In fact, the whole objective of this course is making individual responsible for his or her activities related to health. So you own it. Unless you own the responsibility, you are not going to be in good health or good shape. We know that junk food is not good. Think about your habits. How much junk food you people are consuming on a daily basis? Well, these days you are better off because most of you are in your homes. But I do not know whether you are again eating those home cooked food or you are still consuming junk food. Though we have the awareness, we don't realize the consequences that's going to happen, because you are at your youth right now. The problem might not be that serious, but once you hit 30s, once you hit 40s, you will see the difference, how your body is reacting to the same kind of food that you are eating on a regular basis in your lunch, dinner, and breakfast. Now, the same food is not going to have the same kind of taste for you. These are some of the examples that I am giving because many of us knowingly committing the mistakes. And there are many factors. Factors that affect patient education include physiological, psychological, socio-cultural, and environmental. In pain management, the patient is enabled to understand pain mechanisms in order to reconceptualize their pain experience. Pain is a multiple system output activated by the brain based on perceived threat. Therapeutic neuroscience education aims to help people make sense of their pain and reconceptualize their understanding of the outdated and unhelpful societal view of pain being linked to harm or damage. For example, many patients believe that degeneration is a disease and needs to be cured. The primary goal of patient education should be to facilitate understanding that degeneration is not a disease but a normal aging process and has to be treated with that view. See how we are made medicine dependent through this kind of propaganda that you can cure degeneration. You can cure degeneration. Degeneration is a normal aging process. We all know that. There is no cure for it. And well, at the same time, I am also giving the other development in neuroscience is that our brains are highly plastic in nature. So there was a time when we believed that after a certain age, your brain ceases to develop. That's one part of the story. The other part of the story says that you still can learn many things. Your new neural connections can also begin with a new kind of training, practice, or any kind of behavioral change. So it is not, knowledge is not finite, knowledge is infinite, and knowledge is growing every day. And science that believes in change, change is the science. Science is never static. So the kind of information that we had in the 90s, we hardly have the same kind of information as of today. The world has changed a lot. So similarly, we need to understand, we need to update our knowledge base. What is happening right now and what is good for us, what is working for us. That is more important. And at the same time, let me tell you, most of the uh, information or knowledge that you get, so far as health is concerned, especially on health I'm talking about, uh, it's still evolving. We are still exploring, and whatever is seen to be gospel truth, I mean, people claim like that, yes, this is what is knowledge, not true. It's ever evolving, and with new evidences coming up, we get new kind of results. So it is all the time better to observe yourself as an individual to see what is working for you and what is not working for you, rather than going for a generalized treatment by any expert. Expert knowledge is fine, but expert knowledge should not be generalized to that extent that you would say that, yes, this is the knowledge and others are not of any value. Okay. So when we consider the need for patient-centered care, it is essential that we ask fundamental question when educating people about pain. What do patients want? So in a 2011 meta-analysis, Yelland discovered that patients are seeking the following things. First is pain relief, foremost important, pain relief. Second is functional improvement. They must go back to work and do their jobs. Third is acquired knowledge. Fourth is believed or listened to social legitimization. Fifth is accurate diagnosis, clearly and confidently explained. And sixth is a positive shift in attitude. To add to this research, in 2014, Gifford suggests that people in pain want to know 5 things. What's wrong with me? How long is it going to take to get better? Is there anything I can do to help myself? Is there anything that you can do to help me? And how much will it cost? So therapeutic neuroscience education should aim to address all the above factors by facilitating a meaningful understanding of the contemporary evidence-based related to pain neuroscience. This must be delivered with empathy and compassion for the person's lived pain experience. So what is affecting patient education? in this scenario? Inadequate assessment of pain. Now, when you say that I have a stomachache, I have a headache, do you have an instrument to measure headache? How severe it is, and where in the head it is happening, where in the stomach it is happening, where in the body the pain exactly located, so that you can exactly do that. We do not have those kind of systems available so far. So assessment of the patient symptom should be person-centered and should follow the biopsychosocial approach. Recently, one of my PhD scholars, she has completed her research in adapting this approach, biopsychosocial approach. We can have this approach in many of this phenomenon, and that was used in a juvenile delinquency scenario. What are the biological causes, what are the psychological causes, and what are the social causes of juvenile delinquency? Similarly, the same, in order to understand pain, we can also adapt this approach, biopsychosocial approach. We call it a holistic approach. In order to effectively assess pain and begin management and education of patients, it is essential for clinicians to relinquish some of their authority and empower the patient to become engaged and proactive. Now, tell me, how many doctors to whom you visited for any problem, they discuss the problem with you, or you asked a question and they are very eager to tell you what exactly happened and why did it happen? Or do they have enough time to talk to you? You go with some symptoms and they prescribe medicines, you get those medicines, and sometimes you get cured and sometimes you don't get cured. No one bothers. No one wants to ask why did it happen or why did it not happen. So this is one of the important parameters of patient education, that there should be a kind of less authoritarian relationship between the patient and the physician. Then inadequate understanding of how patient perceives his or her pain. We do not know how patients perceive the pain, whether the perception of the patient is correct or incorrect. Because we do not have an assessment system, so we go by a subjective experience of the patient's pain. Many times, some patients, if they can't tolerate little amount of pain, they would say, oh, it's very painful, it's very painful. So the doctor might prescribe a higher dose which may not be required for the patient. But because of the explanation, how the patient is giving the explanation to the doctor gives higher dose of medicine. And you know what will happen later on, uh, that the patient becomes unconscious because it was wrongly, the medicine was given wrongly. It's not a proper assessment of the pain. So understanding what a patient believes about the causes or consequences of pain will allow the clinician to better inform the patient and correct any misinformation. However, clinicians must approach these conversations with respect in order to earn the patient's trust. Examples of perceptions of pain common among cancer patients include a fear of addiction to medications, concerns about side effects. Discussing pain will distract the doctor from curing the disease. Pain is an indication of the progress of the disease. Next is the variations or differences in the information received. For example, a patient with knee pain is confused whether to do or avoid activities like cycling and walking due to the differences in the information provided even among healthcare providers. Education and pain management will be less successful if information varies among clinicians, and if the care pathway is disjointed with poor communication among team members. there is no clear consensus on the ideal mode, personnel, intensity, or content of delivery. Content of patient education should address aspects of the condition that the patient may have little knowledge about. Some of these aspects will include decreased understanding of the various therapies, poor understanding of the disease and the consequences of poor compliance, poor understanding of clinic visits, and poor understanding of medication doses or regimens. The next factor could be lifestyle, how we manage our lives throughout the day, what we eat, how what is the water content, how much water we are we are taking in a day, and how what is the sleep cycle, sleep habits, right? And what is the nature of job that we people are doing. All of them contribute to the lifestyle. Then the next is the cultural barriers. The format and content of patient education material should be appropriately and culturally sensitive for the target audience, with consideration for language, beliefs, experiences, and values. Factors such as literacy, age group, and socioeconomic status will impact on how well patients will learn from the materials provided. If patients do not understand the information provided, then they will not be able to self-care effectively. So the goal is that you empower the patient. In the health system, we empower the physician, and we also give the authority to physician to decide on behalf of the patient what to do, what not to do. It is not an informed choice, or it's not an informed decision. It's a forced kind of decision, with some kind of fear we are creating in patients, and we try to uh, 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 make them uh, quickly follow whatever doctor says without understanding uh, the uh, positive as well as the negative aspects of any pain. Now, what are the important points in patient education for pain management? Number one, recognize the impact of and evidence for the use of therapeutic neuroscience education and self-management as a critical part of pain management. Number two, design and apply appropriate educational strategies based on educational science. Number three, identify the range of educational opportunities available across therapeutic domains such as injury, disease, medical and post-surgical intervention, with consideration of age, culture, and gender. Number four, consider the scope and evidence for and against various contemporary therapeutic educational styles, biomedical, psychological, and neuroscience, and models such as the stages of change theory and service delivery modes, including face-to-face, web-based group education. Number five, identify key variables which may impact on knowledge outcomes for the patient. There could be self-efficacy, health literacy, comorbidities, and culture. The clinician, such as health professionals' pain-related beliefs, and the message, like the use of multimedia, and the context, like insurance limitations, risk reduction, and injury prevention. So try to identify these variables, how they impact the knowledge outcome of for the patient. So with this, we have tried to understand how to manage pain, how to educate the patient so that patient can take care of himself or herself. Any questions? Any questions? No question?